Okay, sounds good. So I'm Shrey. I'm one of the renal fellows, doing my grand rounds on rationing dialysis. And so, yeah, I will start. I think in the room is Amy and Vic with me as well. So they're here with me. So, I just want to start with sort of three, in my view at least, relatively common cases that we see. So the first one is an 84-year-old woman, sort of bad heart failure, diabetes, breast cancer, hypertension, with fairly significant CKD, who comes in for volume overload that's been refractory to diuretics. And so we are called to evaluate for possible renal replacement therapy for volume. And then the next one is a 36-year-old with widely metastatic cancer, who shows up with AKI on CKD and volume overload and electrolyte abnormalities. And then the last one, I think all of us kind of share a little bit of angst over, is sort of the relatively young person who shows up with alcoholic cirrhosis that's decompensated with AKI, hepatorenal syndrome, ATN, and is oligouric and is not considered a renal transplant candidate. We are called to, again, evaluate for dialysis. So I think these are, frequently the consults that I think all of us feel medically we understand the pathophysiology. I think the sort of, there's a little bit of sort of angst about giving these patients dialysis. And so I just wanted to kind of explore that a little bit. And so, these are sort of the questions that I think we are a little bit, we are cognizant of, but maybe do not discuss quite openly. And so I think the first one is, who should be put on dialysis, and is rationing ever appropriate, and based on what? And then I think the second part of this, which I think is a little bit to what I'm trying to get to, is your patient the person in front of you, or do you also have an obligation to the hypothetical patient, whether someone else in the hospital or the general patient population? And then I want to go over a little bit of how was and is dialysis ration. And this is just the last one, is just an open-ended question, is who should be the person or people or entities deciding rationing. And so, we all kind of understand this, but I think this is just a scope of kidney disease globally, and it's immense. And so, and it is only increasing, especially as more of the world starts modernizing and has more access to equipment for dialysis. And so this is in disability adjusted life years, which I'll talk about as well. And so this is kind of the burden of how dialysis will increase, and it's sort of driven by three large factors, which is population growth, which I believe will start slowing down, aging, which will not, and then sort of the especially is for a variety of reasons, with access to certain foods and lifestyles, the increasing prevalence of diabetes. And this is certainly a rising tide in some areas, and quite the epidemic, especially as globally diseases that we would have frequently thought of as sort of killers in the developing world are now changing to the ones that are sort of we deal with in sort of developed nations. And so this is just the scope of dialysis through 2017. And you can see that the number of patients has increased fairly dramatically, and will likely continue to increase, though there are some peaks and waves. And it will continue to, the prevalence continues to increase year by year. And this is sort of a projection through 2030 that I found quite fascinating. And so, kind of the biggest sort of risk factors of diabetes, hypertension, and then obesity, I think, superimposed on those, as those keep rising, will keep increasing in terms of the projected prevalence and the stimulated prevalence. And so I believe that this is not going to go away anytime soon. And certainly for us, it is job security in some ways, but I think it is also an indication of how unsustainable I think at least some trends could be if we continue to move towards offering dialysis as we do. And so this is kind of the other portion, which I think is the other side of this, is that we have gotten better at keeping patients on dialysis alive, which contributes overall to the overall incidence of patients on dialysis. And so you can see that particularly in the oldest quintiles in the age groups, that we have made quite dramatic successes over the past approximately 40 years that we have been performing this modality. And then this is just a brief sort of plug for the fact that regardless of sort of the underlying cause of kidney disease and the underlying comorbidities, the patients who are on dialysis, the vast majority of them will not receive kidney transplants. And I think I don't have this here, but part of this paper looked at also patients who were listed for kidney transplant, who were referred for kidney transplant evaluation after being placed on dialysis. And within 1 year, approximately 30 to 40% of those patients had died from some other cause. So even the patients that we think of as appropriate for listing for transplant do not necessarily have fantastic outcomes. And then I think, I won't go into the details, but for kidneys, especially in organs in general, the demand, not sort of talking about xenotransplants like pigs, currently far and will far outstrip demand. Demand will far outstrip supply, unfortunately. And so this is just the, if we were to say out of those from who are diagnosed with ESRD in a given year, approximately 85% of them do not receive a transplant. And so this is not a sort of a curative option for most of these patients. And this is just briefly sort of the other side of the coin, that sort of overall mortality has been decreasing, and by a fairly significant amount, and that these benefits to mortality are amplified by transplant. And so I just briefly want to go over, this is quite a brief timeline of how dialysis was funded, and it sort of begins with the Scribner-Quinton shunt, and I think kind of the big highlights here are, in the 1960s, before there was sort of any government funding, there was this policy center that discussed sort of who could and would be considered an appropriate candidate. And then kind of the big things that we have are, the amendment to Medicare that would cover dialysis care. And then subsequently, particularly as the number of patients with end-stage renal disease were placed on dialysis, you started having increasing institution of medicine reports on shared decision-making and discussion of functional status, which I think was starting to come to the fore as the dialysis population exploded quite a bit, and became quite large. And so, and then I think, there's quite a good dovetail with the Choosing Wisely campaign with the ASN and the discussion of sort of palliative care. And so this is kind of a little bit about what I talked about. So, this the Seattle Artificial Kidney Center was a committee of physicians, community and civic leaders, and other sort of healthcare providers who decided essentially who would end up on dialysis. So not to sort of make an overly sort of crass point, but this was sort of the genesis of what is sometimes called a death panel. And so the decision was made by those who would be covered at social worth. And that was sort of decided by this committee based on a patient's contribution to society, likelihood of returning to work, that kind of thing. And you can see how problematic that would be based on the people who are making these decisions. For instance, I think 1962 Seattle, the majority of these people were from relatively wealthy socioeconomic classes. They were likely almost all Caucasian. And so there was a committee chaired by Karl Gottschalk in 1967 about, because of this, as a response to this, because there was such concern about how this was being decided, that there should be federal funding. And that committee actually discussed these criteria as the patients who would be considered appropriate for dialysis. So, and we would not at all, certainly I never think of these as any, few medical comorbidities, less than 54. The assumption would be that patients who would qualify would only make up about 20% of patients who would need renal replacement therapy. And those criteria are based on the fact that they were likely to, quote, contribute to society and return to work. And so when this Medicare subsidization came up, approximately 10,000 patients were receiving dialysis with an annual cost of $280 million, which I believe was something around $1.2 billion, or sorry, $1.5 billion in today's dollars. And so as time went on, I think we all recognized this, that the growing number of older patients with comorbidities were placed on dialysis. And there was a discussion even in the 70s about sort of a deselection committee. So sort of talking to and deciding on who should actually either not be offered or be taken off dialysis. And this is kind of in the 90s and early 2000s is when we started focusing more, in the Institute of Medicine released information sort of questioning the value of dialysis in patients who have sort of limitations on functional capacity or life expectancy, as well as the patient narratives themselves on how what they would value in terms of aggressive intervention, particularly in what are thought to be the sort of the last years of their lives. And so, sort of a truism is that sort of unsustainable trends cannot be sustained. So just in, sort of this decade that's covered here, you can see that the number of, and this is in number of patients in the thousands, the amount has increased fairly dramatically, particularly with Medicare being the lion's share as either the primary or secondary payer, as well as managed care, and only a relatively minor portion being paid for from non-Medicare sources of insurance. And so this is kind of looking at the cost. And you can see that this is quite an increase, and some of this is driven by certainly the number of patients, but also the metrics for quality that are put in, as well as sort of, we've gotten significantly better about complications with dialysis, but at a certain cost about expense as well. This is a little bit of an older paper, but this trend has continued upward despite some cost-saving measures, and then I'll discuss those later in the presentation. And so this actually talks about the cost based on the age quintile, and I think if one were to take any of these quintiles in and of itself, I think what stands out to me most is that patients with underlying comorbidities significantly have a much higher cost if they are on ESRD compared to those who are not. And a lot of that is related to significant and frequent hospitalizations and subsequent, rehabs, as well as the cost accrued by medications and treatment of their conditions. And so I think the most kind of interesting thing, to me at least, is that if one does not have sort of any significant comorbidities, the cost is certainly lower, but it's also relatively even across all age groups. And so this a little bit goes into sort of the per person annual cost of treating end-stage renal disease, which is about 75,000, 80,000 a year, compared to a patient with no end-stage renal disease, which is about 15,000 a year, and about 8% of total Medicare costs in 2017 was relegated to end-stage renal disease patients. And so you can kind of see the breakdown of these funding pies for Medicare, at least in 2012, and this has been relatively stable since then in terms of percentages. And so just briefly, I wanted to go over sort of how do other countries pay or reimburse for dialysis. And you can see that, that almost universally, because of the cost, even in what we would consider sort of low income or middle income countries, there is government funding for renal replacement therapy, whether that be hemodialysis or peritoneal dialysis. And interestingly enough, this, if you look at the sort of the low income number, that is quite low, and that is because quite a large portion of this is out of pocket, meaning it is rationed based on who can pay out of pocket. And so the other part, I think Dr. Young actually had a grand rounds on this that I thought was quite interesting, is that money is sort of quite a subjective, and I think some people find quite gauche to talk about when it comes to human life. And so I think this is kind of the other side of the coin, and that there is a real sort of environmental cost, and that cost is expansive. It includes not only the greenhouse gases that are generated from driving to and from dialysis, for running a dialysis center, for cleaning the water, for generating the plastics and equipment that we reuse quite frequently for dialysis patients, and for healthcare in general. And so, kind of depending on how and which country you look at, healthcare expenditures are 4 to 10% of total greenhouse emissions by developed countries. And so to kind of give you some reference point, I think we talked quite a bit about how much greenhouse gas is generated by sort of cattle farming, and so that is about 2 to 7% in a developed country, and so it frequently exceeds other sectors that we would consider to be quite contributory to greenhouse gases, and the annual mean per capita emission of CO2 is 15.4 tons. With and that's for somebody not on dialysis, and for just dialysis itself, it's between 4 and 10 tons. And so I just briefly wanted to go over sort of, the carbon footprints of maintenance hemodialysis. And this sort of talks about the different regimens, about how frequently doing dialysis are, and whether or not there's any significant benefit to any of the other types in terms of CO2 emissions. And this is normalized to per kilogram of CO2. And you can see that, certainly the lion's share appears to be building and energy use, but quite a bit of it is actually related to waste management, including clinical waste. So as we know, quite a bit of waste is generated during dialysis. And so transporting that, even purifying it, throwing it away, quite aside from the environmental consequences, is quite enormous as well. And then I kind of just wanted to point out two areas where, regardless of the dialysis modality, the environmental cost is enormous. And so this is related to the outpatient visits and the access surgeries for dialysis, and you can see that regardless of the modality of dialysis that's done, how frequently per week, which generally we would, I think, often talk about sort of the benefits of longer sessions of dialysis, that there is quite a significant amount of CO2 emission that occurs annually. And that amount is, even with what we would consider to be fairly standard amounts, is almost 4,000 kilograms of CO2 emission. And just to kind of give a little bit of a baseline, for instance, a gas emitting vehicle probably contributes maybe 100 pounds of CO2, kilograms of CO2 a year. And so this is quite enormous. And so, we define rationing as many different ways, but I think the one that is most on our minds is denying what we think of as a potentially beneficial treatment, on the grounds that is not, it is a scarce resource, and so should not be, and should be therefore rationed for patients who potentially could benefit. And potentially is I think, a charged word, and for somebody, a 10% chance is a potential benefit. And so I think that is a little bit subjective. Healthcare is rationed no matter sort of how we think. So we just some of the ways that we ration are, we certainly do spend more time with complicated patients, with patients that we think have a better chance of having a better outcome, rather than patients who are not going to have a great outcome. We also ration with interventions that we feel are sort of dubious or of no clinical benefit, which is not something I think that some patients would agree with, that they, and I think rationing, at least as it's done in the United States, is done on a piecemeal and financial basis, and it's based on sort of the ability to pay. And the costs of patients who cannot pay, those costs are borne by whatever free labor we are, and other people in the healthcare system can provide as free labor, and what the healthcare systems themselves can bear in terms of taking care of those patients. And so I think these are sort of, I came up with these questions about how should we decide to ration, because it, even sort of stepping back, we do ration even if it's not intentionally. And then who should decide how to ration? And then I think this is particularly helpful as some of us have trained in areas that are somewhat resource poor, is how is historically rationing been done with dialysis in particular. And so just briefly, now that we are talking about ethics, I think we are frequently taught, at least I was taught in medical school and residency, about deontological ethics, sort of based on the idea that every human life has a moral value, and that this is where the derivatives of autonomy, beneficence, non-malfeasance, and justice are articulated to us. And based on that, rationing is immoral. And I will come back to that sort of leap. And then I think we also practice quite a bit of utilitarian ethics, which is where we understand that we try to do the highest beneficence with the lowest cost, or lowest or best ability to kind of distribute scarce resources. And we sort of do that not because we are taught, but because it's instinctive. And so there is kind of a discussion about sort of how do we ration, and how do we decide who to give to. And so there is sort of this idea that there's an egalitarian criteria, which is, first come, first serve, or a free market random distribution. And we don't do it necessarily by who needs it, but by random chance. And then there's also sort of the utilitarian one, which is where we base sort of rationing based on who has the best chance of having longevity, and other values like that. So likelihood of duration of medical benefit, and then sort of the things that the Seattle group, the Seattle committee went over, which include potential or past benefits to society and merit-based. And I think all of us find that to be quite uncomfortable, as sort of those are quite subjective. And so, I kind of just wanted to discuss sort of the two types that we frequently do, which is sort of favoring the worst off. So we tend to ration based on the sickest, and then sort of the youngest, so people that we believe will have good outcomes, as well as sort of the number of total lives saved, and the quality of life years that are maximized for patients. And these are kind of the two terms are frequently used when we talk about disability and quality of life. I think, these are both economic terms that are defined in certain ways. I think that we are familiar with quality adjusted life years. Disability adjusted life years are sort of the time that are taken away because of either premature death or significant disability from somebody's life. And I think there is some concern, particularly among advocates of the disability community, that this is an unfair measure. But this is generally how dialysis quality of life metrics are defined. And so this is kind of what I said in the last slide, but the quality and disability adjusted life years that are defined for using the terms. And so, I think overall, if you were to look at developing countries, that the majority of people who ration do so based on age and or comorbidities. And this is less true in developed nations where there is sort of significant access to resources, but still exists across all nations. If you were to look at sort of surveys sent out to nephrologists. And this is kind of a separate survey that looked at sort of who would be offered dialysis, and this was in the late 90s, and this compared sort of the US, the UK, and Canada. And so, in the late 90s, certainly after World War II, both the UK and Canada have socialized healthcare systems. And so you can kind of see that, at least back then, that there was significant amounts of rationing that would occur, and that there was apparently at least some degree of discordance between what the United States, nephrologists in the United States would offer and what nephrologists in the UK and Canada would offer. And then this, what I think was particularly interesting, is kind of the discussion about who, if they would take family preference into account. And they kind of talk quite a bit about, and this includes not putting the patient on dialysis as well. And so again, I think there's some discordance between the United States and countries that, while as developed, or we think of as developed and have as much access to resources, also have a socialized healthcare system. And I think, and just briefly, I think this is particularly interesting, is that patients with muscular dystrophy have, there's a variety of forms, but I think kind of the most common ones we run into that we see as adult nephrologists generally tend to have life expectancies in the 30s. And so, offering these patients dialysis is considered universal because they are young, despite their relatively short life expectancies. And then I, this is not to cast aspersions on anybody. This is just part of the paper, but they noted that these were kind of the factors that were made in each of these countries to decide about sort of dialysis and who to offer to. And I think it's most interesting that the ability to pay was considered to be the least important, as was their age. And the most important was quality of life, which I think most patients would agree with, and sort of life expectancy. And they point out, however, that of these sort of three groups, the UK, Canada, and US, obviously very few US nephrologists had withheld dialysis because of insufficient funding. However, it also noted that about half of American nephrologists dialyze patients in for-profit dialysis centers. And so the ability to pay is a little bit odd. And so I wanted to also point this out. So this is, I'm sure, I don't know if Dr. Edelstein or Dr. Blaine are on, but this is one of the criteria that is used in South Africa to ration dialysis. So South Africa is, a middle-income developing nation and has dialysis rationing based on government pay. You can pay out of pocket, but and this is how they ration. And I just wanted to point out some interesting things. Is that a category 3 is any, the red one is any, and so excludes the patient, and so theirs includes age greater than 60, and then non-South African citizen, and then significant irreversible progressive vital organ disease. So this is particularly interesting because especially the LVEF of less than 45%. I mean, as of right now on renal 3, I don't have a patient with a normal EF on dialysis, so I think that's interesting. And then kind of the HIV status is considered is not a contraindication. And then I think this is again just one large teaching hospital, and so these were sort of the reasons to exclude from the kidney replacement therapy program at this large teaching hospital. Oh, sorry. And I think, again, interestingly enough, age was fairly significant, as was diabetes. And the only reason I want to pull that up is because we frequently don't even consider diabetes to be anything related to a contraindication, but in especially as a surrogate marker for developing ischemic cardiomyopathy and heart disease, I think that's frequently the thinking. And so this was kind of, my sort of the next part of my discussion is, why do we put patients on dialysis for progressive chronic kidney disease or, severe AKI? And it's kind of, the big ones at least appear to be, a bridge to transplantation, which is not common. It's to prolong life, and it's to improve symptom management and improve quality of life. And the question is, what populations do we think will benefit from starting dialysis? And I think this is particularly the most difficult, is what populations do we think will not benefit from doing it? And so I think Victor Fuchs is an economist who studies new technologies. And he talked about how new technologies have an imperative to use them. So, and this occurs, I think, naturally and instinctively to all of us. We all want to use the newest drug for lupus nephritis or management of hyperphosphatemia. And so I think this is at least thought to be some of the driving factor. And so, kind of to go back to our patients, 84-year-old, several cardiac comorbidities, metastatic cancer, needing dialysis, a 36-year-old with metastatic cancer needing dialysis, and a 44-year-old with not a liver transplant candidate with cirrhosis needing dialysis. And so these were kind of my questions about these three cases. And I just wanted to kind of go over first elderly patients. So, elderly patients who are fairly healthy, and I frequently talk about, frequently hear folks talk about like their 190-year-old patient who still comes to dialysis and walks several miles a day. In elderly patients with one or more significant medical comorbidities, dialysis did not appear to provide much of a mortality benefit for these patients. And so, you can kind of see that these Kaplan-Meier curves basically mirrored each other. And I think even more important than sort of mortality is sort of quality of life. So this kind of goes a little bit back to our disability adjusted life years discussion. Elderly patients who develop who are started on HD or PD, and elderly, I believe, is defined as 70 in this paper. They have fairly significant reductions in their quality of life scores. And I think more importantly, and if you were to talk to these patients and sort of rank their most important goals, it would be to maintain their ADLs and IADLs, and most had seen declines in those after starting dialysis. And kind of, especially among nursing home patients, I think this was a very interesting article, because I think my experience has been that we frequently send patients to, it has not been uncommon for me to see patients started on dialysis after some catastrophic medical event, go to a nursing home for presumed rehab, that after starting dialysis, nursing home residents had a cumulative mortality of almost 60% at 1 year. And so, you can kind of see that the truly dramatic decrease in their ADLs as well. This kind of just goes a little bit more over, as I said, they're especially for folks who are older, I think quality of life is very much tied to their functional status. And so you can see a fairly dramatic decrease after initiating dialysis in these nursing home patients. These are patients who were already in a nursing home, and so they already did not have they already had some deficiencies in their functional status that required sort of additional assistance, and so you could see the decrease that occurs after starting dialysis. My next population is sort of patients with cirrhosis, which I think is frequently a source of angst for us. And so this is kind of a 3-year follow-up for patients with cirrhosis who developed ESRD, and their cumulative survival, which was, I think, quite terrible. And this is sort of all comers of cirrhosis requiring ESRD versus not sort of the quite very high MELD score, quite sick patient that we frequently are consulted about in the hospital. And so it was almost 80%. And so I think this is kind of the flow sheet of that article that sort of goes over patients who had a recent complication would be like a hospitalization for an upper GI bleed or anything like that, and their mortality at 3 years, regardless of their complication rate or not, approached 80 to 90%, so quite high. And among those who have cirrhosis and AKI, this is, I think, a classic article that I was given, at least when discussing these patients, is sort of the amount of patients who developed AKI whether it was hepatorenal syndrome or ATN, who were not listed for a liver transplant, and their outcome. So again, a mortality rate, and I believe this was a 6-month follow-up, is close to 85%, and quite poor. And then kind of the last case I wanted to just briefly go over was sort of hemodialysis and malignancy, metastatic cancers. And this is looking at patients who required renal replacement therapy, who were in the ICU and quite ill, and this included, critical care use, and then also separately required invasive mechanical ventilation. And so at 6 months, regardless of the type of malignancy, if you had ESRD or AKI and needed renal replacement therapy in the ICU, whether it was through mechanical ventilation or not, your mortality at 6 months was 92% for any sort of, irrespective of the kind of cancer you had. And so quite poor. And then, I briefly just wanted to talk about this. We do not have great tools to determine who would benefit from dialysis or who would survive. This, I think, was the only one I could find that sort of discussed the 1-year survival for patients with these sort of debilitating conditions. And this was something like developed, quite a bit of time ago when dialysis was first starting to become more widely used. Hence the addition of metastatic solid tumor or HIV. But these still hold quite true. Nowadays, for instance, I think we would not consider AIDS to be at all prohibitive, as treatment makes it a fairly controllable chronic disease. But we do not have great tools to determine who will or won't benefit from dialysis. And I think I know that this, especially because I know many here are medical directors of dialysis units, have talked about sort of the benefits, at least, kind of ignoring the environmental costs, because I think that is outside of the scope of this article. But I think in terms of controlling costs in general, financial costs, we talk a little bit about sort of bundling as a way to control financial costs, and the change in 2011 with bundling dialysis and the medications that came with dialysis, and sort of the dramatic improvements that occurred in terms of financing it. So I just wanted to go over a couple of things, and I thank Dr. Ferguson for this, because I sort of through the grapevine heard about this but never read about it. And so I actually got in touch with somebody I knew in residency, who sort of he's a physician, but he does a lot of healthcare economic stuff. He was a Robert Wood Johnson scholar, and he gave me this article that just got published like quite recently, that looked at sort of the changes to cost. So, this I think is a big one where once the cost change was announced, the bundling was announced, excuse me, the amount of EPO used dropped dramatically in dialysis units. And I think this was considered a win for a variety of reasons, because this had a downstream effect of cardiovascular mortality as well. And this was around the time, I believe, that there was a discussion about changing the targets for what hemoglobins you shoot for. But I think it is interesting. And so the cost went down for these dialysis units, and the cost went down a little bit for Medicare as well. But the interesting thing is that if you look at the transfusion rate, that went up fairly dramatically, not surprisingly, I think, in some ways. However, most interestingly, these costs of transfusion were not generally reflected on the dialysis units. These were back-ended to the hospitals these patients were admitted to for transfusion. And so this looks at sort of the inpatient and outpatient spending changes after the 2011 bundling changes. And you can see that, among the groups, this is broken up into the quote unquote EPO responders, the high, medium, and low responders. And you can see that the amount of sort of outpatient spending did not sort of dramatically change. However, the amount of inpatient spending went up quite a bit, and that was thought to be related to at least some of these admissions for needing transfusions and for anemia as well. I kind of just wanted to, these were kind of two quotes that I think really sort of discussed how when we try to control behaviors through cost cutting and rationing that way, that, you know, as shown, we find no evidence that these changes resulted in providing any high quality care and did not change much in terms of the number of patients per station, staff, or patient infection rates. And the dialysis facilities increased their profits by drastically cutting EPO doses and shifted the costs of anemia management to others through an increase in transfusions. And so I think, you know, I think even in those situations, it is challenging to find ways to ration equitably, particularly with these situations. So I think, you know, I'll just kind of end with this, which is, you know, of those sort of 3 patients that we have, which, if any, should be offered dialysis, and should dialysis be considered medically futile ever? And, you know, if we do not ration, then who will and how? I will end by just saying that I think the one kind of subject I wanted to avoid a little bit is sort of discussion of, you know, what is the patient's wishes and shared decision making, because I think it seems to me that autonomy and decisions that patients make has been put on a premium. And when we sort of talk about of those, you know, 4 moral qualities, the discussion of justice, there is a discussion of something that is known as distributive justice, which is that we should at least consider a potential patient when we are making decisions for the person in front of us. And I think that's a little bit different than at least how I did my residency, was very much about sort of advocating only for the person you see in front of you. And so I just thought this was an interesting talk, and I just wanted to end a little bit and say that I don't have any answers to these questions, and I think these are just questions that I find keep me up quite a bit, and I just thought it was an interesting topic. I certainly don't want to cause any fires or anything, but I just thought it was an interesting topic. Yeah, I think I'll just leave it up to any questions if anybody has any.
Yeah, nice talk, Shrey. I would like to just share with you my experience with dialysis rationing. My first 6 years as a nephrologist in South Africa was with rationing, and I will never forget it. Conscience-wise, we had meetings, dialysis rationing meeting every Thursday at 12 o'clock, where we decided whether people lived or died, basically. And I mean, there were multidisciplinary meetings with the dialysis nurses were the ones that had the most say. And like 1 in 10 people were accepted for dialysis, and the other 9 were basically died. And if you were over age of 60 and you had diabetes, or you were not transplantable, you had 0 chance of getting on dialysis. And the meetings got very messy. I can remember people's biases come in. Like, we had a patient who was a racist, basically, and he wouldn't be dialyzed next to any people of other races. And he was going to get accepted for dialysis because he fulfilled all the criteria. And I jumped up and I voted no, and I said this was ridiculous. And there was a whole fight going on, and we got into a lot of trouble. And the meetings got messy because people's emotions were involved, and with life or death. The way the situation in South Africa is now, there are 120 nephrologists in South Africa, 60 million population. That's 1 in nephrologists per 2 million people. There are 20 pediatric nephrologists in South Africa with a huge pediatric population. So the pediatric rationing is even worse because there's basically 20 nephrologists. The way it is now is that if you're in the private sector, you have health insurance, you'll get dialysis no matter what, which is the minority of the people. If you're in the public sector, which the majority, you will be subject to rationing and likely not get dialysis. It got so heated in South Africa that it was take a patient who was turned down for dialysis. A young patient took this case to the Supreme Court of South Africa, and the Supreme Court upheld rationing, and this patient died. So basically in the US, you cannot practice rationing because Medicare makes rationing illegal, and basically the Supreme Court will never uphold rationing unless Medicare is changed. So if you try and practice rationing, it's illegal, I believe, because of the Medicare saying everyone's entitled to dialysis. It's horrible when you try and do rationing, by the way.
Shrey. Charles, I just want to clarify, I mean, it's not illegal to ration care by Medicare. And I think Medicare would appreciate if physicians, especially in the nephrology space, correct, would, choose patients who really, can get the most benefit of dialysis. I mean, Shrey raised a very good point, and why dialysis is so costly, Shrey, and you're absolutely right. Binders and management of secondary hyperparathyroidism adds close to $1 billion in cost. I think it's 750 million the last time that I saw, when you put in this calcimimetics and other vitamin D analogs and whatever phosphate binder du jour is coming out. And you could argue that a lot of those therapies, correct, have not improved outcomes. And I think the data is very clear. And actually, we have come back 20 years after, we have come back to the old calci trial, because we spent all this money and effort in trying to improve outcomes. So you raise a good point that a lot of the care that we provide could be at least less expensive. But I don't think it's illegal. I mean, I think it's within us to really provide the best care that we can for our patients when it's indicated. But that's just want to add that as a thought. Very nice, Ray. Very thoughtful grand rounds.
I would think if we decided not to offer dialysis to a patient, and that patient went to the Supreme Court and said, I need dialysis offered to me by Medicare, the Supreme Court would say, yes, you're entitled to it, right?
No.
No?
I disagree with that completely, because nobody's entitled to anything, right? Like, it's a medical decision of risk versus benefit. So what we are discussing here is that is the risk of dialysis worth the benefit? And I agree that there are patients where we know that there is no potential benefit of dialysis. And I think one thing Shrey didn't touch upon is that, unfortunately, we all have our personal beliefs, and we among ourselves will not agree who is sort of not the right patient for dialysis. And I think for me, that's the most challenging, that I may think it's futile, but another person on our team, I'm not even talking about non-nephrologists, may have a completely different opinion. And I don't know how we can reconcile that, because everyone has very divergent beliefs on this topic.
And you can't predict, basically. I mean, we turned down patients that went for dialysis in the public sector, and they were you can't predict who's going to do well. I mean, you can, but there are 90-year-old patients that do well on dialysis, and there are young patients that do badly. So you can't predict always.
Shrey,
I think this is, I'm
Yeah.
sorry, go ahead.
No, go ahead.
I wanted to touch on the last case, which refers to everybody else's points. The HRS cases, especially young people, is something I think we all feel squeamish about at times. I particularly struggle with young people who have young kids, especially in COVID, and they didn't get to see their kids. And I don't think there's a right answer. I sometimes just think about my experience as a resident in oncology. And when you think about some oncology treatments, the treatment longevity is in terms of months. They get 3 more months of life. And when we compare it to, what we'd be able to offer, yeah, a lot of these patients will die in 3 months, but what would they do with those 3 months? And maybe they'd be able to see their kids, or, it really depends on the goals and the patient's decision. And I think it's really tough to place a black and white kind of like, we're not going to do dialysis on any patient with type 1 HRS. That becomes really challenging when you consider the entire patient situation. And maybe 1 month would be incredibly valuable. And so I really struggle with these patients. And I thank you for bringing it up, because I do not think there's a right answer at all. And so just having the discussion that names how challenging it is for all of us is really valuable. So just thank you, Shrey.
Shrey, Stu here. 2 quick comments. One, my introduction to rationing was as a medicine intern, where there were, we called them death rounds. And so I was charged with presenting a patient to a dialysis group to see if that patient was eligible or not eligible for dialysis. And it turned out that the patient I presented, who was in fact a minority back when, was refused. And to this day, I wonder if I had done a better presentation and known and been prepped to how to do it if things had been different. And so that's one of the reasons that kind of the rationing side of things has been very important to me. The second issue is, and this may be angels on the head of the pin, the 3 cases that you presented today, to me, don't have the feel of rationing. They have the feel of ethics rather than rationing. And by that, I mean that I can honestly say in my career, up to the last 2 months with COVID, when we in fact have rationed, I don't think I've ever been in a situation where I've truly ration care for all of the reasons that you alluded to. And so I would push a little bit and say what the presentation, not the presentation, what the cases today were more aimed at the ethics of who should be started rather than resource utilization, et cetera, et cetera. I don't know that everyone feels the same as I do. It's a subtle difference, but it's important to me, having been, like Charles, part of the rationing process in the distant past.
So Stu, if I understand you, Isaac here, you're saying that even if resources were not limited, those patients from a bioethical standpoint would not be dialyzed.
That's my feeling, that the way Shrey teed them up, I don't think, at least if I were the attending nephrologist, that I would offer dialysis. With reference to Shrey's question of how that decision is made, I would meet with the primary care team. I would meet with the ethics folks or the palliative care folks and make it as a joint decision, but it doesn't feel like rationing to me. That feels like ethics.
Yeah, I agree with Stu, and I think that's a really important point, that when decisions are hard, it's our job to make recommendations to patients in what we feel is our, their best interest. And so, not with all the details, I think it's our obligation to realize that the benefits of dialysis in these settings generally doesn't outweigh risks and other complications. And it weighs on us to make those recommendations to family and teams versus, hey, do you want dialysis? All these different menu items. And so I agree with Stu that these cases don't quite feel like rationing and fall on our shoulders to really think through this and make the best recommendations that we think are for the patient, which is sometimes to not offer dialysis.
I mean, I don't know, if you take an alcoholic, basically you tell the family, well, if he stops drinking today and we dialyze him and give him a liver transplant, he can live a normal life. That's kind of really difficult, because maybe the patient would say, I'm stopping drinking today, and would qualify for having a normal life versus dying in the next week. That's to me is rationing, I think.
Yeah, Charles, you up the ante on that one though, meaning you put the liver transplant into the equation, which to me ups it. That's a different issue than dialysis only.
Right, but you're taking a patient that you could basically cure almost, and saying you're not getting that treatment, where you know that it's possible that you could do everything for this patient.
No,
Charles,
no.
I think, yeah, I think Shrey, one of the most important things that Shrey brought up and that his generation of docs is going to have to deal with is dialysis isn't as good in the acute setting or the chronic setting as, we've all thought. And that a lot of times we start people and it's not this cure, and we can support people the best we can, and their outcomes are still very poor. And so I think this is an extremely important issue for the current generations of docs to grapple with and recognize that dialysis in both the acute and chronic settings just isn't that great. And we have to be innovative in our therapies so people don't need it in the first place.
And to piggyback on Sarah, what you just said, and also Shrey, this was an excellent presentation. This is information that we have to be better at communicating with our non-nephrology colleagues, because we never see these patients up front in the acute or chronic setting. And sometimes there's an expectation set by outside providers who might not have all this information. So I think this is not only important for nephrologists to continue to understand and be comfortable with, but also it's something we have to communicate and educate all of our colleagues on.
Thank you, Anna. Thanks, Sarah. Great comments. Shrey, nice job. Thanks, everyone.
Thank you.